Hello friends, today I'll be talking to you regarding chickenpox, measles, mumps and rubella. In fact, today I'm starting infectious diseases, and infectious disease is the one topic where more of the facts are there. Okay, factual cheese are more, concepts are little less to explain. So in that way, your work and my work become a little easy. But when we talk about facts, you have to remember, like what is the incubation period, what is the period of infectivity, etc. What is the cycle of this life cycle of any organism. So all these are facts. There is there is no concept. Okay, but wherever concepts will be needed, I'll be definitely explaining you each and everything. So as usual, I'll be covering all whatever relevant to all these topics, and there are certain recent advances. Again, that will be the highlight of today's topic. So first of all, we talk about chickenpox, and that is so-called varicella zoster virus infection. But there is big confusion. Now comes the first question of microbiology, very, very important, and this, believe me, this point is not known to 90% students are not aware of the point what I'm going to discuss in the next 2 minutes. This is the rank number one getting question is this, right? So I just told you regarding herpes, but are you aware there are at least 7 to 8 types of herpes? Write down. So first of all, herpes, HHV. HHV is herpes, human herpes virus. This human herpes virus, this is HHV. Okay. Point to be noted, this varicella zoster is a type of human herpes virus, is type 3. It means there must be other types also, yes. And that what I said is a rank number one getting question is this. So next point regarding, let us see, we have a human herpes virus 1. It is this what is known as a herpes simplex virus. This is herpes simplex virus. Type 1, so-called type 1. Type 1. The human this thing is HHV1 is human herpes simplex virus type 1. Well, then we talk about HHV2. This is herpes simplex virus type 2. It is type 2, a human herpes simplex virus type 2. Then we have HHV3. It is this what is so-called varicella zoster virus. Varicella zoster virus, right? Virus, V for virus. But again, one more rank number one getting question. It is this virus which can lead to herpes zoster. It is this virus which can lead to herpes zoster, and it can lead to chickenpox. Chickenpox. That means these two diseases which we commonly encounter in our clinical practice also, they are by the same virus, that is so-called HHV3, so-called varicella zoster virus, V4 virus. Then we have HHV4. This is so-called Epstein-Barr virus. Epstein-Barr virus. Epstein-Barr virus. It is this virus which lead to infectious mononucleosis. Epstein-Barr virus, which is associated with infectious mononucleosis, And we also know that this virus is so sorry for the inconvenience. So what I do, I hope the problem of audio not in the visual. So I'll just quickly read out for those who missed the audio part of this. So I was talking to you that human herpes virus, it has got 8 types. Type 1, it is the herpes simplex virus. Type 2 causes herpes simplex virus. Type 2, it is HHV3, which is the so-called varicella zoster virus, which causes herpes zoster, what we also call as shingles. And we have a chickenpox, the other disease caused by HHV3. HHV4 causes Epstein-Barr virus, which is the cause of infectious mononucleosis, and it also lead to associated with lymphomas. HHV5 causes cytomegalovirus. Then 6, it causes Rhesusella infantum in the infancy. Then HHV7 causes exanthema subitum, again in infancy. And HHV8, which causes Kaposi's sarcoma in the HIV patient. So I hope you, there was some audio problem, but you could write it, right, sir? Well, with this background, we move further. Well, when we move further means, so as I told you, today I'll be talking to you regarding chickenpox is the main topic talk of the day. Chickenpox, so-called herpes, human herpes virus 3 is the one. Okay. Well, let's talk about what the virus is. Let's talk about first virology or microbiology, whatever you can say. And in this, let me show you the first picture of this. This is electron micrograph of the varicella zoster virus. But what actually it looked like, this is the question for you. This is the actual picture for you. If you want, you can click. Now, what is the most important thing in this? Well, it's a virus, but you should not forget only one line. It is double-stranded DNA virus. This is the most important question in the entire virology of this. It's a DNA virus, right? So, and what's the common between all these herpes? They have a lipid envelope. This is the one. Lipid envelope is there, and that is common in almost all the herpes variety. So friends, as far as virology is concerned, 2 important points. It's a DNA virus, and the one thing which is common in the structure of all the viruses is the lipid envelope in this patient. In addition, there are glycoprotein spikes, you can see. This is you can see, I can even draw a diagram for you, for your easy. This is the double-stranded DNA inside, and this is the lipid. And here is the glycoprotein spikes. They are glycoprotein, GP I am writing in short, spikes. Okay, and of course, and there are nucleocapsid which is surrounding that DNA and tegumentum. But only thing, for exam point of view, this is the most important, and this is the second important thing that you got to know. So this was our virology. I hope you are clear about the structure also. Now next question comes. How the transmission occurs? How the disease is really transmitted? Disease is transmitted, transmission of the disease. This is a tricky question. If they simply ask the question, then it is aerosol. This is an important question for you. Aerosol means by droplet. And as for an example of droplet in the era of COVID nowadays, COVID is again, they say, is spreading by droplet only, right? So here also same droplet is there. But in addition, this now comes the gold medal getting question. In addition to this droplet, in fact, write down the answer, all the students, this question only for the student. Write down the answer, what is the other method of spread of the disease? This is the rank number 1 getting question. Other than droplet, which is the other mechanism of spread? Question only for the students. Other mechanism of spread of the disease. Quickly write down the answer. I hope you have written it also. Well, in this there are 2 extra clinical applied in mechanism. The clinical applied number 1. There are 2 clinical applied. Number 1, it is also spread from the skin contact. From skin contact of the patient, especially when he or she has blisters in the skin. These blisters are highly contagious. They are highly contagious. It's a very, very important question. Second point, in fact, the question usually comes, this is 99.9% language will remain the same. Just now, after in a few minutes only, I'll tell you that there are stages of the infection, what we get in the skin. And finally, you get blister, and after blister, we get scales or so-called scab. It is a dry. Scab is the crust, what is left when the blister dries up. When it dries up and scab are left or scales are left. These are non-infective. So 99% question throughout the world come like this only. The patient is infective up to what stage? Up to stage of blister, they are infective. But once the question come like this, when the patient becomes non-infective, when all these blisters are dried up and scales are formed. So scales are not infective. There are 2 clinical applied that you should never forget. Okay. Well, we got some lovely question on infectivity also. Which structure is infective? So droplet infection, that means patient should be. So in that way, third applied point is, the third clinical applied, patient should be isolated. Patient should be isolated so that they don't spread. They don't spread the disease to other parts, other people around, right? So we understood the purpose. Same in COVID time, I don't need to tell you the purpose of isolation is there. Next point. After that, now we talk about pathophysiology. What happened in the pathophysiology? Well, source of infection is patient only. Patient. Source of infection is patient. Right? That's the patient from where now. Well, other person inhales the droplet. Other patient who gets, and these virus, they infect the mucosa of the upper airway, or the droplet even can land up in conjunctiva also. Point to be noted. They can even land up in the conjunctiva also. This point is not known to most of students. Well, so they land up, and after that they go, the proliferation, they go to lymph nodes. Usually of the upper airway, lymph nodes, and they take about 2 to 4 days. That means virus has entered the upper airway usually, okay, and from there it goes to the regional lymph nodes, and during this the virus is dividing, and this is known as primary viremia. This is so-called primary viremia. And this stage this occurs in around 4 to 6 days. This is about 4 to 6 days. After that, you got second round. After you get this is a primary stage of viremia. After that, you have another round of viremia where it goes to many internal organs like liver. The virus enter many other organs like liver and spleen. This occur in around 14 to 16 days. Okay, 14 to 16 days. And in this, mainly the capillary endothelium and and the epidermis is involved. It is this stage when capillary endothelium is involved and even epidermis is involved. Point to be noted that these occur in the secondary phase of the viremia, right? So ultimately, one more point. So it now, as I told you, this infection even has reached the epidermis also, and now start the skin lesions start. Skin lesion can be variety of lesion can be there, including sometime there can be little bit of skin hemorrhage also. There can be epidermal hemorrhage also in some cases. Why? Because even the capillary endothelium is also involved. That's a reason why patient even can have a hemorrhagic tendency also in some cases. Not everything is seen in all the cases. Okay. Well, now, next question is, what is the attack rate? Attack rate is very high as 90% attack rate. This is again a very, very important question for you. Attack rate is as high as 90% chance. That means if the patient is exposed to any normal person who is exposed to an infective person, this 90% chances are there that he may catch the infection. That is now this comes the clinical applied. Clinical applied is that's why patients should be isolated. The patient anyway who is suffering should be isolated, because if the normal person get droplet from this infection, 90% chances are there they will get it. That's why if you have seen some cases of chickenpox, it usually happens in the families. One family member suffer and other they catch infection very fast because nobody told them the patient should be isolated. Same is what is being done for the COVID also. Same. A type of quarantinization is advised. Why? We want the disease should not spread from one person to other. I think I don't need to elaborate on this point, especially in the today's era of COVID. Okay. Well, then who are the patients usually suffer? The age is about 5 to 9 years. 5 to 9 years is the usual age of infection, is the most common, but it can happen to the elderly people also. It's never said. Usual age is 5 to 9 years. Now, what are the clinical features of a case of chickenpox? Well, we have incubation period. We have 4 phases. First is incubation period. The first phase is incubation period, and the incubation period. Second phase is prodromal phase. Third phase is exanthem period, where the rash come. Exanthem period. And the fourth is recovery phase. 4 is the recovery phase, right? So first of all, we talk about incubation period. It is about 10 to 21 days. this is very, very important. 10 to 21 days is the period. Yeah, right. So in this, patient is totally asymptomatic. Patient is asymptomatic. Point to be noted. Patient is asymptomatic. This is again a point to be noted. Patient has no symptom. The virus has entered the body. It is viremia is going on. Primary viremia and secondary viremia, I told you. The usually patients are in this. They are usually no symptom at all, right? After that stage comes the prodromal period. This is also known as pre-eruptive phase. Pre-eruptive phase. That means eruption, skin infection has yet to come. Pre-eruptive phase there. This is just lasts for 1 to 2 days. 1 to 2 days, and it is this time. At this time, when the patient start having nausea, vomiting, body pains, headache, maybe some fever also. Headache, non-specific, what we always call as viral fever, body pains, nausea, diarrhea, some loss of appetite, etc. Okay, and with this, in this time, when the patient comes to the doctor, it is always taken as an ordinary viral fever. Why? There is nothing to suggest that it is really has a chickenpox is there. Then come this lasts for about 1 to 2 days. And after that, well, patient has come to you, that means to the doctor on day 1 of the fever. Examine the patient, perfectly all right, there is no sign of any skin lesion, taken as an ordinary viral fever. Okay, you prescribe some usual antipyretic drug to be prescribed at this stage, and maybe after 2 or 3 days, patient is brought to you again, and now he has come in the exanthum period, or so called as eruptive phase. Point to be noted, before that it was pre-eruptive. Point to be noted, in pre-eruptive phase, the simple fever, etc., body pains were there, but there were no skin lesion. That means on day one, it is not possible to diagnose practically, or not practically, because there is no evidence. You can't think of chickenpox. Well, now comes the eruptive phase. Okay, so now the rash comes. As I told you, the hallmark is eruptive phase means skin rash has appeared. What is the classical feature of this rash? It is patient has fever. So that means the fever will continue with the rash. So fever plus rash is what is patient come to us. It's not necessary that patient may come to us on day 1, patient may come to us day 4. By the time it is fever and rash is there. Now what is special thing about this rash? It is a rapidly evolving rash. It is a rapidly evolving rash, and it has mainly in the chest, abdomen. What about face? It can happen, but less common. It is again, so it is more toward the center of the body. So you can say that way also, it is more toward the center of the body. It is very, very important to talk about, because we used to have one disease, so-called smallpox. Okay, it used to be a deadly disease, and that was very disfiguring, and that was which was going to involve main their face, and one of the main reason it was really disfiguring the face, loss of eyesight, etc., etc. But thank God it was eradicated long back, long back. In the people of our age, my age to be more precise, we all used to have a chickenpox vaccine, and if you happen to see a generation older to you, you can find, look at this thing, you will find three skin mark, huge scar tissue will be there, which were what we were given vaccination in our childhood. Smallpox vaccine was given, and due course of time it was eradicated. So nowadays we don't talk about smallpox at all. And now comes the gold medal question for you, especially for those. Universal question is this. Only one question they ask in smallpox, nothing else. Well, this question only for students. When this disease was eradicated throughout the world, that means virus is not there, yes. But scientists never want that virus should be eliminated. And the only one question relevant to smallpox is, these viruses are still preserved. They are still preserved in certain laboratory in the world. In which cities these viruses are? Labs, of course they are preserved in labs. In which lab of which cities and countries they are preserved? This is the only question, especially for those who are appearing for Indian PG, is a ranked number one question. Nobody knows the answer. Don't worry, try to get the answer and let me know also. Ranked number one getting questions. This question is, in which cities, in labs of which cities these viruses are still preserved? Smallpox. But at the moment I'm talking about chickenpox. We come back. Well, so when these, now let's see what are the characteristics of the rash that we talked about. Well, the rash, write down, they are macules. They are erythematous macules, to be more precise. Erythematous. Then they become papule also, and they become blisters, and finally they become scab. Okay, macule, papule, blister and scab, so-called, this is what we call as pleomorphism is there, so-called pleomorphism. Pleomorphism, you get different types of the rash, right? So now let me tell you some basic about dermatology, okay? What are these macule, papule, blisters and scab? Basic concept about dermatology. Integrated approach, dermatology. What is this? This is the skin, and you are getting a rash like this. You are getting a rash like this. So we will call as a macule. Macule means it is with us in the surface of the skin. It is just at the same level. We are getting some change in the color of the. So if I have to show you this normal skin, and in this normal skin we are getting is something like that, maybe reddish spot is there. So we will call it to be macule because it is in the same level as of the skin. Now if we are getting like this, it is raised from the, you can even, that means you can palpate it, you can palpate, you can find. If you just palpate it, it is raised above the skin or it is visible also, then we call it to be papule. Okay. Now if this papule contain liquid, If it contains liquid, then we call as blister. Blister also known as pustule. Blister is the word, usual word we use, blisters. Blister means now you can visibly it contain liquid, rays but contain liquid. And finally it dries up. It dries up, and whatever dead material is left, that is known as scab or scales. And the clinical applied was, it was highly infectious, as I discussed previously, and scab are non-infective. The commonly asked question, in which stage is the patient, when we can say a patient has become non-infective? Classical universal question asked in all the exam. Once the patient become, when all the blisters are gone, and if it has gone into scaly phase, they never talk on days, they only talk about when the scale will be there, the patient become non-infective. So very infective and non-infective is the answer that you got it, right? So ultimately they keep on appearing, rash, the new crop coming up, and that is so-called pleomorphism. That means at one stage you may get macule also, papule also, blister also, and in the final stages you may even start getting scales also, right? So let me show you some of the pictures to you. Some of the pictures, yes, of chickenpox you can see, okay, red or pinkish bumps, macules are there, and here the blisters, and finally you are getting crust or scab or scale. You can see at one scale you can see this is the one, even in one patient all the stages can be there, so-called pleomorphism is there, right? After that look at this, okay, now this child has got more rash on the face. Why I deliberately showed you this? Well, I told you usually it is more in the abdomen, chest, maybe arms. Face is comparatively less involved, but I never said the face will never be involved. It is involved. You can see more rash. Okay, more rash. Now this is the look. This is the what is the classical around the chest, abdomen. Okay. Classical thing is presence of lesion in different stages of development on the same time. That is the classical MCQ they ask. And this entity, what is known as pleomorphism, is there, right? So in this particular slide photograph you can see we are getting blisters, we are getting some scales also, okay, some scales are also there, little bit of macules are also there, or papules are also there. So what carry home message is they can have different stages at one time. So a quick recap, if I have to summarize the description of rash in chickenpox only in 20 seconds, they are usually with fever. Pleomorphism, macule, papule, blister and scale all can be there at one place, more toward the center of the body, right? After that we talk about so what are the complications that can occur in this patient? The complication which can occur in a case of chickenpox. Number one, bacterial superinfections. Bacterial superinfection. Especially in skin. Especially skin by Staphylococcus, Staph, or maybe even Streptococci also. maybe streptococci also. Okay. Why this happen? Because patient keep on having itching. Itching is a feature of the rash of the chickenpox. The patient tend to do itching, maybe involuntary also, and that can do the superimposed skin infection can be there by this thing. Okay. Next point, it can lead to pneumonia. Second complication is it can lead to pneumonias. In fact, it is considered as one of the most serious complication, among the most serious complication of a case of chickenpox. It may develop, especially in around 20% of the children. It's a very high percentage. Okay. Well, in this classically, patient can have like now cough, fever. In addition to that, patient may have pain chest. Patient may start developing pain chest. This is due to pleurisy. Even patient can have hemoptysis also. And in severe cases, even cyanosis can occur. Okay, even cyanosis can occur. Okay, this is the so-called chickenpox pneumonia is there. Third complication, other complication is CNS complication, and it can lead to a type of aseptic meningitis. Aseptic meningitis. In fact, the term when we use aseptic meningitis is a generalized term for any viral induced meningitis. So aseptic meningitis doesn't mean that it will always caused by chickenpox virus. Any virus can lead to, of course there are certain known viruses which can, we use the term as aseptic meningitis. Why? Okay, now come the gold medal question. So let's talk about clinical applied. Clinical applied, that the patient of chickenpox has come to you, he is under your treatment. How will you suspect that patient has developed meningitis? Okay, the clinical applied. This patient now will start developing severe headache. Patient may even have, of course, high fever also. High fever will be there. Severe headache. Then altered sensorium. Even altered sensorium may be there. And there may be neck rigidity. They are not the feature of chickenpox as such. They are all the feature of any meningitis. So we get meningeal features including neck rigidity, Kernick sign is positive. That I'll all discuss when I discuss neurology. As of now, just to inform you that when the meningitis occurs, when the patient has got chest infection, he will have cough, hemoptysis, pain chest. Then go for chest X-ray. And if you are getting picture like this, patient is going into meningitis. Now, very, very important point again, when you examine the CSF in this patient, CSF glucose and proteins, they are normal. That is the one point which really differentiate, because in TBM and bacterial meningitis, these are altered. So as of now, in CSF only cell count is slightly increased. In contrast to TB meningitis and bacterial meningitis, where the cell count is increased drastically, here only mildly increased. So a quick recap, that patient can have aseptic meningitis. The finding will be what? How will you suspect? Patient having headache, altered sensorium, high fever and neck rigidity is there. Okay, in addition to that, patient can have problem of, some patient can have cerebellar ataxia. Some patient can develop cerebellar ataxia. There may be involvement of cerebellum, and that can lead to ataxia. Okay, now again a frequently asked question. And usually when we talk about cerebellar ataxia, the classical applied, how will you suspect? How will you suspect that patient has got cerebellar ataxia is there? Now the clue point is drunken gait. Drunken gait. This is the clinical applied gait. So drunken gait is cerebellar ataxia. High grade fever with headache and altered sensorium is meningitis. Cough hemoptysis is pneumonia, and skin infection are visibly directly also. Okay. Then after that we talk about a entity so-called perinatal varicella. Perinatal varicella. Okay, we call as perinatal varicella if this chickenpox occur 5 days before delivery or within 48 hours of delivery. Okay, deliveries. Well, in case of pregnancy, usually the newborn is not protected. Usually the newborn is not protected. Because of immature immune system. Immature immune system. Okay, immature immune system is there. Now, how we really diagnose the case of? So we learned about the problems. We learned about the clinical feature of a case of chickenpox. Now let us see how we really diagnose the case of chickenpox. As far as diagnosis is concerned, it is usually not difficult. Why? It is visible. Any experienced physician or pediatrician can very well diagnose the chickenpox. It has a classical presentation, so something which is evident visibly. So we don't need much of the lab investigation other than the routine investigation. Okay. However, if somebody really insists on diagnosis or maybe exam point out, then you can go for the varicella zoster virus specific IgM antibodies can be investigated. Okay, it can, but usually not required. Again, exam point of view only, or we can diagnose by, if you really want, it can be diagnosed by varicella zoster virus DNA also, detection of DNA also. This can be detected by reverse transcriptase PCR, RT-PCR, reverse transcriptase PCR, polymerase chain reaction. RT-PCR is reverse transcriptase polymerase chain reaction, is again used. In fact, this is a very hot word nowadays because COVID people are using this technique also. So by and large, if I have to tell you how we diagnose, majority of time we diagnose only by inspection only. But I did mention about IgM antibody, I did mention about RT-PCR. Usually they are not needed, not required, but for exam point of view, I added this point also. As far as treatment is concerned, treatment is usually supportive. What about antivirus drug like acyclovir, etc.? Usually not done, because this should be given in very, if the patient lands up to you in very first 24 hours, then only if you use, then only it's not going to cure the disease. It may just reduce the maybe duration of illness by 1 or 2 days. So if you look into any of the literature, they have mentioned about the drug like acyclovir. But by and large, again, they are not very useful in treating the case. But acyclovir. So, in the exam point of view, you should know, if somebody asks you which drug you will use, acyclovir, then we can use famiciclovir, or we can use valacyclovir, can be used in this condition, okay? Can be used in this patient. What about vaccination? Vaccination, active live attenuated vaccine is there, and it is given as 1 dose any time after 1 year. 1 dose any day, any time after 1 dose after 1 year of the age, and the booster dose is given after 6 to 9 months. Booster dose is given 6 to 9 months after the first dose. This is the preventive method for chickenpox. So I hope you learned a lot of things about chickenpox. Now we go on to the next topic of the day, is measles. Well, measles is again a very widely discussed topic in all the exams. So it is again an acute viral infection. It is acute viral infection, and again fever with rash. This also come in the category of fever with rash category. Rash category. So it is a RNA virus. This is an important point to remember. In case of chickenpox, it was DNA virus, and it belonged to family of paramyxovirus. It belonged to family of paramyxovirus. Family. Virology, basic concept. But this is the most important thing. They are least interested in knowing which family it belongs to. And in viral infection, they are simply interested whether it is a RNA virus, DNA virus, single strand, double stranded, blah blah. So it is a RNA virus. Okay, and genus is morbillivirus. Genus is morbillivirus. Single serotype is known. Something special. Single serotype is known as of now. Single serotype is known as there. Now, let me show you the picture also of this virus. Okay. Yeah. This is a measles virus. Well, what is important in this is only this, the most important thing that you got to remember. Lipid layer is there, and other things are there in the diagram, but what you got to know is RNA virus is there. Well, how it is really transmission? Again, second thing important is transmission. It is again by droplet infection. Again by droplet infection is there from the patient. Okay. So that means source of infection is again patient. Source of infection is again patient. And after that, we talk about what is the pathogenesis of this patient. Well, in the pathogenesis of this, when the patient get infected, the virus, it may involve the which part of the body they are primarily going to infect. One is skin, second is conjunctiva, and very, very important, it involves the mucous membrane of the mouth, maybe airways also, intestine also. Okay. And classically in these patients, there can be hyperplasia. This is a very, very important question. There is hyperplasia of the lymphoid tissue. Especially in appendix, where you may get multinucleate, giant cell, okay, and they have a special name for this giant cell, and that giant cell is known as Warthin. Finkeldy. Giant cell. Okay. Similarly, as I told you, they may they involve the airways also. It may involve the lungs also, and they can lead to interstitial pneumonitis. And there also we get Hecht giant cell. Giant cell pneumonia. This is a pet question of all the exam. This is far more commonly asked question. Hecht giant cell pneumonia is seen in measles. Pet question of PGI Chandigarh in Indian exam and MLE or MRCP. This is very important question. When they talk about Hecht giant cell pneumonia, that means they are correlating with measles. Can't afford to lose this question. Okay. Well, discussion of measles is incomplete unless we talk about Koplik spot. I think this is the most important question they ask in measles, and this is the second common question they ask in measles. It consists of serous exudate. It is seen in the inner mucosa of the mouth, and it's a generalized inflammatory response. It is an inflammatory response. Just like we have an inflammatory response in the skin where we get a rash, similarly we get a rash, a Koplik spot in the mouth also. Okay, and this is the virtually diagnostic. When they talk about Koplik spot in the exam, it means you are dealing with nothing. You are dealing with measles. It's so important to talk about. Okay, so we learned the basic pathophysiology and pathology also, what is going to happen. With this, let's talk about what are the clinical features that we get in a patient. The clinical feature that we get in. So in this we get a fever. We have a, first of all, in this again we have a prodromal phase. Prodromal phase. In the prodromal, that lasts about 3 to 5 days. That means before the rash we have a prodromal phase 3 to 5 days, and in this case patient has fever, then dry cough, conjunctivitis, right? And after that, as I talked to you regarding complex spots, they are grayish white. Now I am describing. I just told you previously that they are in the mouth, mucosa. Now that our description of complex spot, they are grayish white, dot-like finding, just like a grain. Let's say some grain of small grain of sand. That is what they describe, the complex spot is there. Okay, and they are usually reddish, and they tend to occur opposite the lower molars. Right? But they stay for small time. They just stay for about 12 to 24 hours. So they don't stay for a long time. So if you are examining the patient and if you are lucky enough to see the complex spot, that will really help in making a better diagnosis. But as for exam point of view, complex spot means measles, right? Well, then come the rash. Rash start as a faint macule. It always start as faint macule. So macule means it is just lying in the surface of the skin. It is not raised, which is a papule. Okay, it start in the upper part of the face, just behind the ears. It start behind the ears, or maybe upper part or lateral part of the neck. Maybe along the hairline. Okay, or maybe behind. By and large, what I want to say, they tend to occur more on the lateral side of the face, neck. Okay, later on it become maculopapular rash. Maculopapular rash. That means now it is be slightly raised above the skin also. Then it spreads very fast. It spreads very fast and goes down the body also. Very fast. And it may go down the body also. So virtually it involves the whole body. Now let me show you some of the beautiful pictures. The rash, some nice pictures. Maculopapular rash of the measles. And this is face, and now it has more on this part of the face, some on this part of face also. What I wanted to say was more on the lateral side of the face is more commonly involved. But as the disease start increasing, it may involve the front side of the face also. Okay. So now look at, this is the what exactly looks like. This is the way. Behind the ears, like this, neck, lateral part of the neck, is the classical finding. Is what we describe as bookish picture of rash, This is the bookish picture, the rash is there. Okay. So now, later on, scattered lesion on the trunk also, it is going toward the trunk also. Okay. Well, after that, it remained for, in some cases, in some patient, it may become hemorrhagic rash, and that is known as black measles. And that is known as black measles. So if you talk about black measles, what is the black measles? It means hemorrhagic rashes there. Hemorrhagic means it is bleeding is there. Okay. And this rash will stay for 7 to 10 days. After that, the rash disappear, and by and large, patient recover completely, right? So now come the question again, how to diagnose? Again for antibodies, usually not done, because all these diseases are self-limiting. So clinical examination is the best, but if the antibody is same, you can go for IgM antibody. But what is more important to talk about? How to treat this case? Again, like chickenpox, it is supportive treatment is there. But one thing which really has a definite role to play is vitamin A. Vitamin A is definitely supposed to reduce the severity of the disease, reduces morbidity also. So vitamin D has, so whenever they talk about measles, they will talk about Koplik spot and they will talk about vitamin A. What else they are going to talk about is vaccination. Now, some recent updates have come up. Let me tell you recent. Previously, we were giving measles vaccine at the age of 9 months. Measles vaccine at the age of 9 months, and MMR was given at the age of 12 months. But now it is gone. What they do is they do MR1, MR2, and MR3. What is MR? Now the latest guidelines, it is M for measles and R for rubella. Mumps they have removed. The reason being the incidence of mumps has gone down drastically. Okay, so that's why the new guidelines are you use MR1. MR1 is given at the age of 9 months. Then second vaccine, that is again vaccine is MR. Vaccine is same MR, but we call as dose 1 at the age of 9 months, dose 2 at the age of 18 months, and dose 3 is at the age of 5 years. So the recent update is MR1, MR2, that means first dose at the age of 9 months, second dose at the age of 18 months, and third is at the age of 5 years. These two are must, and many of the associations say this is optional, but you should go for MR1, MR2, and MR3 is there. Okay, right, sir? So this is all about measles. I hope you learned a lot of things. Now, what complication can occur in this patient? Complication that can occur in the case of measles is it can lead to otitis media, it can lead to pneumonias, it can lead to encephalitis. They can lead to encephalitis. Remember, in chickenpox it was aseptic meningitis. Here it is more likely to have encephalitis, of course. Okay, it doesn't mean that it will never cause meningitis, not, but more in the textbook they talk more about encephalitis, we get it. Here again we get altered sensorium will be there. but there will be no neck rigidity will be there. So in encephalitis, fever with altered sensorium fever, but no neck rigid. No neck rigidity is there. Other uncommon complications are Guillain-Barré syndrome, Guillain-Barré syndrome is a one, and sometimes it can lead to some focal deficit also. Focal deficit in CNS like hemiplegia, but they are very rare complications. So by and large, don't forget these three complications. The three complications, otitis media, pneumonia, and encephalitis are the most common. And now come the rank number one question. I mentioned to you regarding encephalitis, altered sensorium occur, but usually it is so-called SSPE. Encephalitis, it is subsclerosing. Panencephalitis. SSPE they call as. Why it is so special about it? It is a problem which occurs after many years. After many years of the infection. Suppose the child was not vaccinated, and the child was not vaccinated and he got infection at the age of maybe 9 months or 10 months. The child got infection is there, and this virus remained dormant in the body. Maybe at the age of 20 years, when that boy had become a young boy of 20 years, and now it come as SSPV. He now will come with fever with altered sensorium, and that is SSPE. And that's why SSPE is termed in the category of slow virus infection. So SSPE is virus infection which was causing acute problem in the infancy, but now if the problem occurs at the age of maybe 20 years, we call as slow virus disease. Slow virus disease means, point to be noted, the virus entered in the body at the age of 1 year but manifesting at the age of 20 years. So that's why they put in the category of SSPE. Okay. So as far as treatment is concerned, is again, as I told you, for SSPE is symptomatic treatment is there. Symptomatic treatment is there by and large. Okay. In fact, in all encephalitis patient, remember, first of all, encephalitis is the diagnosis of exclusion. And any encephalitis is diagnosis of exclusion. And of course, or detail about encephalitis I'll cover when I take neurology. But as of now, just to inform you that patient of meningitis measles can manifest even decades later on also. Right? So after this, we talk about mumps. One thing I've told you that now the disease is not very common. That's why even they have removed the MMR, they converted MMR. Initially MMR, M for measles, M for mumps, and R for rubella. Measles, mumps, rubella was the combination that we are giving till very late, but recently they changed to MR. M for measles and R for rubella. Mumps they have removed. The reason being the disease incidence has gone down drastically worldwide, maybe due to active vaccination or whatever reason it may be. So now they have changed it. Well, when we talk about mumps virus, they belong to family of Paramyxoviridae. Paramyxoviridae. Okay. They have a single-stranded RNA. Single-stranded RNA. Okay. Single-stranded RNA virus is there. So it's again RNA. That is an important point to remember. And due to this, they are single-stranded. They don't have segmental RNA. They don't contain segmental RNA. This is a very, very important point, because there is something called resortment. There are two things. One is antigenic variation, and other entity is resortment. These two entities are not seen in this important negative point. Is a very frequently asked question. This antigenic variation, and what are these? What is the virology behind this? This I'll be talking to you when I take influenza. Then I'll talk about antigenic shift and drift, etc. I'll be talking to you. But as of now, important negative point to remember that these entities are not seen in mumps virus. Okay. Well, after that, let me show you the virus also. Picture of virus. That's must, so that you will remember. You will keep the image. Yeah, this is the virus. Mumps virus is there, right? Lovely picture to look into. This is the RNA virus. One thing I always say, forget everything, but don't forget whether it is the RNA virus or DNA virus. This is the only thing he is going to ask you in your microbiology or virology. Okay. Well, there are a few things that you should remember. First is you can write down single-stranded RNA virus. This you already have written. There are two major surface glycoprotein, heme agglutinin and neuraminidase, and the fusion protein. Heme agglutinin neuraminidase is the one glycoprotein, and other is fusion protein, number 1 and number 2. Two types of proteins are there. Fusion protein and the heme agglutinin and neuraminidase. Okay. Well, when you talk about mumps, in the virology, just remember RNA and the two proteins, heme agglutinin and fusion protein, and after that we talk about how the really patient come to us. It is again an acute viral infection. Point to be noted. Okay. And the hallmark is swelling in the parotids. Parotid gland swelling, usually bilateral. Write down. Parotid swelling is the classical feature. Swelling in the parotid gland is the hallmark. It is usually bilateral, but uncommonly it can occur unilateral also. The patient has fever. So the patient comes with fever and bilateral swelling in these children. Again, it is pediatric age group which is involved. That is what we talk about mumps classically. Right? So as I told you, the incidence has gone down drastically. But what are the things that we are really worried about this patient? What are the things? Let me show you. Now this picture. The incubation period is 14 to 21 days. Note it down. And communicable from 6 days before and 9 days after the facial swelling appear. Now look at this thing. He has swelling in bilateral. Parotid swelling are seen. And two things that you got to remember in this patient. What complication it can lead to. That's they talk more about the complication rather than the disease. As such, there is nothing to ask special. The only problem was parotid gland. So parotid gland is in mumps, coplic spot in measles, and pleomorphic rash in chickenpox are the classical exam question he is going to ask you. But what is extra thing he is going to ask you about mumps? In mumps, they will talk about orchitis. After parotid gland, he is going to talk to regarding orchitis, and that can lead to sterility also in some cases. It can lead to sterility also in some cases, right? Second problem is regarding it can lead to encephalitis. And third, it can lead to pancreatitis. It can lead to pancreatitis. But out of this is the most widely asked question. Most widely asked question. In measles, they talk about SSPE. They talk about HECT pneumonia. Here they talk about orchitis. Okay. Well, after that, as far as lab diagnosis is concerned, we don't really, again, it's not needed. However, they can again investigate for antibodies. And moreover, as I told you, disease, why people are not very aggressive in investigating? Because all the disease what I mentioned, chickenpox, measles and mumps, they're all self-limiting. They're all self-limiting. That's why it is when that we know very well the disease is self-limiting. And it's quite evident is there. Quite evident is there. So that's why, and moreover, we don't have any specific treatment. So treatment is symptomatic, it is visible. Chickenpox you can diagnose by examination. Measles you can diagnose. Mumps you can diagnose. Treatment is symptomatic. So no aggressive investigation are required. But as a physician, you should know the important complication and you have to keep a watch. In the exam also they are going to ask you complication, which I mentioned previously also. Right? So regarding the vaccine, again I told you, nowadays we are using only MR, mumps is not using it. Righto? Yeah. After that, we come to the final phase of today's talk is about rubella. Rubella is important, so-called German measles. We call as German measles also. Okay. Rubella, also known as German measles. Okay, it belongs to the family of Toga virus. It belongs to family of Toga virus. Okay. Point to be noted is it is known as German measles. Do not get confused with measles. Okay, measles is different. German measles is altogether different entity. So if I have to show you the picture of this, so it is also known as 3-day measles or German measles. Belong to the family of Toga virus, and it is a RNA virus. Point to be noted. Okay, and they carry heme agglutinin. Note down this point. Is a RNA virus. They contain heme agglutinin, and they multiply in the cytoplasm of the infected cells. Lipid bilayer membrane is here also. Single strand RNA are the two things that you got to remember in the virology. So as of now, we talked about DNA virus, RNA virus, and the RNA virus is there. Okay. Well, as far as incubation period is concerned in this case, incubation period is on an average 2 to 3 weeks. Is the incubation period is there. And something very interesting to talk about. In this case, as far as rubella is concerned, if they have to ask a question rubella, 99.9% they will ask about congenital rubella syndrome. 99.9% the question will be about congenital rubella syndrome. Okay, that means the child may get the infection in the intrauterine life and he will have some manifestation or the exam question. However, it's my duty to tell you how the patient will come to us when the patient develops germinal measles after germinal measles, any patient, more in problem of the infants. Again, just like any fever, they come with a fever. They come with fever and they get rash more in the extremities. More in the extremities. Okay, and they usually last for 3 to 5 days. The rash lasts only for 3 to 5 days. Not a very long rash is there. It will be self-limiting. Okay. Even sometime, as far as investigation is concerned, we can go for antibody, and virus can be cultured also. This virus can be cultured also, but not done. Again, what I try to tell you that there is something called culture also. Just for exam point of view, normally we don't go for culture, etc. Because all the disease, as I've been telling you, they are all self-limiting. We don't need to go for very aggressive investigations, not needed. Now let's talk about more about postnatal rubella. As I was talking to you, it occurs in neonates. Number one, it occurs in neonate and childhood. In fact, whatever diseases I covered so far, out of these measles and and rubella, measles and germinal measles are more likely to get involved below 1 year. Chickenpox, any age, but usually in around 3 to 5 years. Even mumps also, little on the older children. But two diseases, measles and germinal measles, in the infancy. But remember, they can occur in adults also, but less common. Viremia develop in 7 to 9 days, last for this once a virus enter the body, okay, and lead to antibodies. So that's why they say that the disease is self-limiting, is there. Now come the question, is there any specific feature? There is no specific feature of the rash is there. It's more of a clinical diagnosis with experience that people make up. Yes, one thing is there. The rash is usually maculopapular and morbidly formed rash is there. And they tend to occur. You can see like this also, more on the back or maybe on the arms, on the limbs. These rash can be there. Okay. Now come the main thing is congenital rubella syndrome is the one which is the most important thing that we talk about. Well, few more complications that we talk about in rubella. Number one, it can lead to arthritis. Write it down. Joint pains. This we have not come across so far anywhere. Second, it can lead to thrombocytopenia. They can lead to purpura or they can lead to encephalitis. Point to be noted that encephalitis has been there in measles also, mumps also, rubella also. Point to be noted, in chickenpox we got aseptic meningitis. Point to be noted, in chickenpox is the only one where we got blisters blisters and scab, and this type of rash we did not see in any other condition so far. Okay. Well, now I'll talk to you regarding congenital rubella syndrome, regarding protection. I already discussed, right? So, as I was, serology is not done usually, but I mentioned here just to update you. For everything, measles, mumps, rubella, we can do serology to detect antibodies against, but repeating second time, this we not do usually. Now we should talk about the most important part is congenital rubella syndrome, without which the talk of this is grossly incomplete. So, what the classical triad that we get in these patients? One is cardiac, other is cataract. Okay, one is cardiac, cataract. In the cardiac, what is the most important thing? They can have patent ductus arteriosus. Patent ductus arteriosus is the classical finding that we get in these patients. Okay. Now, and the child is born, maybe in the very early phase, the child may get cataract. And now come the questions. Now come the question for the students. So it is mandatory that any lady who has not been vaccinated in the early childhood, the vaccination should be done. Should be done. Suppose the lady is going to get married. The lady is going to get married soon. Is she be given vaccination? Yes or no? First question. Number two, if she is given vaccination, then for how long she should not conceive? This is the question for you. Write down the answer. Write down the answer. Write down the answer that the lady who has not been vaccinated for the rubella and she is to be given vaccination, then if she will be given vaccination, yes or no? If yes, then she should not conceive for how long? For how long she should not conceive? The answer is yes, she should be given vaccination and she should not conceive for minimum 6 months. Minimum 6 months. Okay? For 6 months she should not conceive. Well, one more complication that can occur in this congenital rubella syndrome is microcephaly. Microcephaly. They are the classical thing that we see in a case of congenital rubella syndrome. And this, if you have to go serology, you go for IgM serology. So in this patient, you go and check for IgM serology against the rubella virus, right? Well, in addition to that, in these patients again can develop encephalitis. Encephalitis is a problem that can happen in a patient of congenital rubella syndrome also. But by and large, most important thing is regarding PDA. This is the most important question as far as exam point of view is concerned. And of course, microcephaly and cataract is the problem, right? So it is mandatory that a lady should be given vaccination before marriage, but she should be strongly advised. So for minimum 6 months, ideally for 1 year. For minimum 6 to 12 months, a lady should not conceive. This is again a very, very important point I talk about. Okay. So this is all about measles, mumps, rubella. Tomorrow topic will be regarding cholera and typhoid. They are more of more commonly asked topic in the exams. Schedule of classes will be like this: malaria, leishmaniasis, falciparum worm infection. Well, as I always say, whatever those of you who joined recently, content is from all these books, and these classes are useful for whom? MLE Step 1, MRCP, Australian exam, and those who are preparing for Indian exam. But those who want to get top rank in AIMS, PGI, NEET and next. UG student in any year who want to get gold medal in any university exam, they are the premium classes. How to study, rule of 7. Whatever has been taught to you, speak out in front of somebody else for 7 times. It will take only 7 minutes to finish the whole lecture. Go parallel with us. Whatever I am teaching, so you read same thing. Do all the tests. SPT. Discussion is the best way of studies. Discussion is the best way of studies. Okay? Why? Because when you are discussing the two things, suppose you have joined, your colleague has also joined the classes, then you are discussing. And with discussion, things become very easy and interesting. Otherwise, studies is the most boring thing in the world. Most boring thing. Who want to study? Everybody want to enjoy. You want to go for picnic, movie, and etc. etc. You want to go for dine and dance. But nobody want to study. But I always say, do discussion among the group of friends. You will find that things are changed. You will really start enjoying the classes, enjoying the studies also. So our aim is to convert you from a star to moon. I want to make you like a eagle which fly above the clouds. Rains don't disturb them. Premium classes for the premium students. You can very well contact me on my personal WhatsApp number also.